Hi everyone, Lou Bernardi. I'm president and founder of BritePath Benefits here in Woodbury, New York. Today I want to talk to you something about that we've been working on called the Real Glossary of Health Coverage and Medical Terms. Most people out there, especially plan sponsors and members, are familiar with the insurance terms glossary that you might get, might be included in your open enrollment manual or some sort of handout to the employees to make them familiar with common health insurance or healthcare terms. Things like deductibles, copayments, coinsurance, out-of-pocket limits, durable medical equipment, things like that. A lot of acronyms in this business, so they're really helpful sometimes to be able to put those in front of people so that they could better understand the benefits of their insurance, how those deductibles, copays, coinsurance might apply towards their benefits when or if they incur some sort of healthcare treatment. But what we noticed is the things that we talk about most, and a lot of the solutions that we implement, people are not familiar with whatsoever. They're very confused when we bring up some of the cost-saving solutions or some of the real, kind of the ugly side, the business side of healthcare and health insurance. And we want to do something about that because we understand that the consumer is not going to understand or be able to address the spiraling out of control, skyrocketing healthcare and health insurance costs unless they become a more informed consumer. So one of the first things we want to talk about are rebates, not to be confused with rebating, right? Very much the same, but rebating is illegal. Rebating, and this was drilled into us when we were going for our insurance licenses, rebating is an offer made by an insurance agent to a policyholder in exchange for the sale. So it is illegal for an insurance broker to promise the customer a percentage of the commission, a premium savings, or even to give keepsake gifts to people, maybe tickets to a Broadway show, a sporting event. Technically, you cannot promise that in exchange for a sale. In New York, for example, you're allowed to give keepsake gifts away as long as they don't cost more than $15. So I could give someone a book. I could have a group together, share a book with them, give that to them in exchange for coming to a presentation. That would be fine as long as it doesn't exceed $15. Completely understandable. We want to make sure that the transaction is kept, kind of like a sacred event. We don't want people buying business because of their ability to give back to the consumer. We want to make sure that the consumer is protected. What hasn't happened is protecting the consumer when it comes to pharmaceutical benefits. Rebates, kind of the same idea, but in the pharmaceutical world, a rebate is a price concession paid by a pharmaceutical manufacturer to an insurer, a pharmacy benefit manager, or a plan sponsor in exchange for preferred placement on the coveted RX formulary or the prescription drug list. Okay, so why is this so important? Because pharmaceutical companies will artificially inflate the price. They don't give a discount off of the true cost of their medication. They artificially inflate the price of that medication, and then behind the scenes, after the transaction's taken place, they will rebate typically to the pharmacy benefit manager, possibly the insurer directly, and if you're self-insured and you're doing it in a transparent manner, that rebate still, if it exists, would pass through to the plan sponsor. That's what we're targeting when we're doing self-insurance with an independent TPA and pharmacy benefit manager. If we can't remove the rebate completely, we can keep it in there, but we want to make sure it passes through to the consumer. So let's talk a little bit about the flow of medications and then the money. So the flow of medication is pretty straightforward. Pharmaceutical company that makes the drug will send that to the wholesaler or the distributor. This could be, on its way to a pharmacy or on its way to a medical setting like a hospital or some sort of facility. So typically we'll go to the wholesaler or the distributor. It'll make its way to the pharmacy or to the hospital, for example, where it is picked up by the patient, either or. So now that transaction's taken place, the patient gets their medication. Now the payment. Now the flow of the money is where the confusing or the complexity starts. So your patient, your member, if you're a plan sponsor, has an out-of-pocket cost for that medication. If they go to the retail pharmacy, they have a copayment. Depending upon where that medication falls on the drug formulary, they have an out-of-pocket cost. It might be a flat dollar amount like $10, $15. It could be a percentage of the cost of the medication, maybe 50% of the cost of the medication, capped at a certain dollar amount. It's not uncommon for like tier 3 medications. They can be non-formulary brand name medications or specialty medications to have a percentage assigned to them up to a maximum of $300, $500, $800, whatever the case might be. The patient pays that. They're gonna hand that over to the pharmacy, and now the insurer is going to pay the balance at the pre-rebate price. This is the artificially inflated price because it's taken into the account what the manufacturer actually wants to get, plus the rebate that they promised somebody in this transaction. So the insurance company is going to pay that up to the total pre-rebate price to the pharmacy, or it could be a medical provider at a hospital, for example. That vendor, the pharmacy or the facility, is going to send to the pharmaceutical manufacturer the acquisition price of that medication, whatever they agreed to pay. So they're going to make a little bit of profit here. Could be a transaction fee, but there is some profit, especially on the provider side, probably more so than on the pharmacy side. The manufacturer, the pharmaceutical manufacturer, then is going to send that rebate to the pharmacy benefit manager. It also could be a hospital system that's getting this rebate. It could be the insurance company in some cases. And the pharmacy benefit manager, who might be collecting a $10,000 rebate on a $20,000 medication, is going to keep a portion of it and generally share a large sum, maybe 75 to 80% of that rebate, with the insurance company. Your insurance company, who paid the pre-rebate price, is getting a significant rebate on that. This is important because this is not reported on any of your claims reports. You're being charged against your plan the total pre-rebate price. They're making a huge profit behind the scenes. And by the way, the insurers and the pharmacy benefit managers are typically, or in many cases, under the same umbrella company. Okay, so there's a relationship between these two companies. The pharmacy benefit manager is deliberately in there to make this transaction on behalf of their insurers. So one of the things that we do when we self-insure is we make sure that this rebate gets back to the plan sponsor, not to the insurer. Or we eliminate the rebate completely. Again, the plan sponsor, and this is important because their premium for the following year is going to be determined based on that claim spend, plus trend on that claim spend. And let's say there's a 10% trend. That 10% trend is being applied to the pre-rebate price. That's the dollar amount that's in your claims cost. It's what they use to determine the expected claims for the following year. It has a huge impact on premiums. Prescription medication, especially specialty medications, are becoming a significant portion of total claim spend. It used to be 10, 15, 20%. It's now becoming more like 30, even 35% for some organizations. And it can be a high percentage of the pooling charges on a fully insured plan. Those high cost claimants can more and more frequently be coming from pharmacy claims. So hopefully that was helpful.